Okay, we'd like to welcome everyone to the February 2023 Wisdom Wednesday webinar presented by the Special Education Resolution Center. We are very excited today to have Dr. Sarah Rich and Dr. Brittany Stein from the Oklahoma State University Bridge Center as our presenters. And our program manager, Joanne Blades, will be introducing our presenters shortly. My name is Rob Kiter. I'm program coordinator at CERC and very glad to be with you. I'll be hosting today's event. And I just wanted to go over a few logistics with you before we get started. Today, we do have one handout for you, and it's in the chat. You can download that file. And we also have the PDF of today's PowerPoint presentation that's there that you can download. And these will also be on our website because we are recording this webinar, but we wanted you to be able to grab them now if you wanted to. You won't be using your audio or video during the webinar, but you can engage using emojis with chat, such as thumbs up or down or raising your hand. And we also really love it when our participants have questions that we can respond to. So if you have any questions for the presenters today, you can submit those by typing them into the Q&A section at the bottom of your screen. It says Q&A. The panelists will be able to see those questions, and depending on the time available, they may be able to address those. So please feel free to do that. We are providing real-time closed captioning during this webinar, and you can click on that CC Live transcript button at the bottom of your Zoom screen to turn on or off the captioning, as well as you can also, I think, adjust the size and some other settings like that to personalize it. As I mentioned, we are recording the webinar and we'll be making the recording available on our website for future viewing. It should be up by next week. One more thing, at the conclusion of the webinar, you will receive in the Zoom a short survey, and it won't take you long, but we ask you to complete this. This is really important for us, not just with the State Department of Education, but we really take this feedback seriously. We're always looking at how we can improve our webinars and want to know how they are impacting you. So that's really all that I'm going to share. I hope you really enjoyed today's webinar. And at this time, I'm going to turn things over to our program manager, Joanne Blades.
Good afternoon. Great afternoon. It's noon, isn't it? Well, welcome. We're excited to have you here, and we're excited to have Dr. Sarah Rich and Dr. Brittany Stein come and do this webinar for us on interpreting psychoeducational evaluation results. There's always a lot of questions in parents' minds. Sometimes teachers need a little bit of training in how to read an evaluation and actually what do all those scores mean? How do they come up with that? What are the different tests? And so we're hoping that the information is very valuable to you. It will be archived, as Rob said, and that's helpful that you can refer others. If you're an advocate, you can refer parents. If you're a school person, you might refer teachers if they're having trouble understanding what these things mean. So welcome, ladies. I'll be reviewing your chat box and take it away.
Well, good morning or afternoon. We already established it's afternoon. Like Joanne mentioned, I am Dr. Brittany Stein. My colleague is Dr. Sarah Rich, and we're partnering with SERC. We're so thankful they had us here to present from our OSU Bridge Center, where we do consultation and technical assistance on all things multi-tiered systems of support, as well as special education. And, you know, a lot of times when I show up to these presentations, the first thing I ask is, who is this person talking to me and why do they know what they know? So Dr. Rich and I are both licensed psychologists, but also nationally certified school psychologists. So before we both came to work here at the OSU Center for Health Sciences in the OSU Behavioral Medicine Clinic, we both were in the trenches working at different districts across Oklahoma as school psychologists. In the day-to-day, doing psychoeducational evaluations, trying to implement multi-tiered systems of support, all the things. Now we both work at the OSU Behavioral Medicine Clinic, where our day job is on the other side of the fence, where we're doing psychological evaluations, and the results get taken to the schools and interpreted and used. So we're in the unique position of being on both sides, which gives us a little bit different perspective. And we're excited to walk with you guys through what it takes to do a comprehensive psychological evaluation, but then interpreting the results. So the objectives of our presentation today are going to be learning a framework for reviewing these reports. I always think it's helpful to have a systematic way of looking at things. And Rob has already graciously put in the chat box the handout. So you have the information where it can walk you through a checklist of what to look for. We want you guys to understand the important psychometric properties when reviewing the data that comes your way, be it data that's collected internally in your school or data that's coming from an outside evaluation. And then as we walk through, it's always helpful to have examples. So we've got a case example to show you. So we're going to kick off with talking about the purpose of an evaluation. And when we look at that, can you switch next slide? Thank you. When we talk about the purpose of an evaluation, we're really looking at this identification process, identifying what needs the child has, and then determining what programming they need. It's as simple as that, right? Just simple. So, purpose of an evaluation, you've got your 3 core aspects. We've got to determine, 1, does the child have a disability as defined by IDEA? This is going to be important. We're going to come back to it. So keep that in the back of your mind. Next step is to gather the information that will help us determine what are their educational needs. Key in on that, educational needs. So not just all needs that they have, but what educational needs they have to be successful in school, and then to guide decision-making about what programming they need to help remedy those deficits or those needs. So all 3 of those things are what we need to look for. And that doesn't always match up with evaluations that are currently being done. We'll talk about that. Next slide, please. So child with a disability, this is straight out of IDEA. We're not going to make it complicated when we can just pull it from the language. But what I want you to key in on, you've got listed here the different categories that we talk about for special education. But the child has, these different disabilities listed and needs special education and related services. So you've got to have both components. And I know it sounds simple and like I'm hitting on it and you're saying, Brittany, I've heard you say this multiple times, but it's really that critical, because that's the designation between the different levels of support that a kiddo may get in a school. And now, when so many of our schools are working really hard to put in place excellent multi-tiered systems of support, the range of options for support isn't just limited to special education, right? We have special education, IEPs, we have 504 plans, and then we have tiered interventions. And so just because an evaluation is done that shows that a child needs extra support, it may not be to that level of what special education provides. So again, one of those really critical factors that we think about. Next slide. Here it goes, got the transition. Okay, so Dr. Rich and I last week went to a phenomenal conference, National Association of School Psychologists, where I met up with colleagues, and I also attended a session on the updates to the DSM. We have our new DSM-5 revised version out, and the session was wonderful because it wasn't just diagnosis updates criteria. It was designed for school-based practitioners and talking about the intersection between DSM and IDEA. And there's something that I took away that I'm going to share with every presentation that I go to, is keeping in mind that a medical or DSM diagnosis if you're working in the schools, should direct your attention. But IDEA should direct your action. So if you think of DSM diagnosis, attention, so when we get it, we focus on it and we look at what it says, but IDEA directs our action and is our actionable steps of what we're going to do next. I think that can help a lot in our IEP teams and with our qualified examiners on really determining what to do with the information that we get. So just a little quick, I know most of you watching this are probably like, I've got this down, but just give me a second to review through it real quick and may help give you some language to share with others. So we have two different models of classification or diagnosis that we're talking about here, wherein DSM, the Diagnostic and Statistical Manual of Mental Disorders is our guide for that. I've got one on my shelf right over here. And it is what psychiatrists, licensed psychologists, medical doctors use to make an official diagnosis. So it's considered a medical diagnosis. We're looking for specific criteria that meets a disorder. And it's really important to recognize that just because a child is on an IEP doesn't necessarily mean that they have a medical diagnosis. On the flip side, IDEA is in this educational framework where we're looking at what categorization they need to be in for different services. We're looking at the child, like we said, meets the criteria for a disability and has an educational need, so both on there. And it's not a licensed psychologist or a medical doctor or a psychiatrist just making the determination. It's that team with a qualified examiner making the determination together. So when I worked in the schools as a school psych, I worked with my admin, my general ed teacher, my sped teachers, other related service providers. We met as a team to determine what was best for this child. When I'm in my office and I do a psychological evaluation, at the end of it, I hand over the paper and I say, here's your diagnosis. That's not all I do, but essentially it's just me. There aren't other professionals and we're not determining diagnosis by consensus. And that's really different. Just because I give a medical diagnosis or another provider doesn't mean that the child automatically gets an IEP. And I might say that again for those in the back, because I think it needs to be said sometimes, a medical diagnosis does not automatically equal an IEP. Or something else to keep in mind before we move on. This is really important because the DSM, if you know how the DSM was constructed, over time, it has, for lack of a better term, ballooned. So it keeps getting longer and longer and more inclusive of different concerns. And, you know, there are questions of if we're over pathologizing everyday concerns. And so every time there's a new iteration of the DSM, we've got new diagnoses, new criteria for disorders, whereas IDEA has been much more stable throughout the span of that law. There have been things that have been added and tweaked, like developmental delay, other health impairment, but it stayed pretty consistent. And that's an important thing to consider as well, especially given things like our newest version of the DSM changed the criteria and made it more rigorous for autism spectrum disorder. But then we're looking at IDEA, and what does it have for autism as a category? And so just remembering that those two don't equate and being able to explain that not only to parents, but also if you have advocates in your building or agencies, community-based mental health services that are in your building may not understand that, and they're in that medical diagnosis mode and not in special education mode. So that's why we take so much time on this section, because we want to make sure you guys have the words to explain it, because quite frankly, this is an area I've seen a lot of schools and parents get very frustrated over. So next slide. So when talking about our general assessment procedures, we're going to go through the step-by-step process, and you're going to notice that there is the same word in every section. DATA. I'm pretty sure if Sarah or Dr. Rich was going to get a tattoo of anything, it would be the word data somewhere. We won't talk about where. No, it'd be on our arm, right? So we start with the review of existing data, where we're gathering the background information and referral information. And then we're moving into the collection of new data, then synthesizing it all together, and then reporting it out. And it's really helpful if we look at all these steps in the process, because it can be easy in the being flustered and excited about getting a student's support to forget that you have to do all these steps of the process. You know, I have parents that I'll come in and I'll be collecting new data after we review the data, and they'll want the diagnosis right then. And I have to tell them, I have to do the synthesis of the data. It doesn't just spit it out. Or we forget to do a really comprehensive review of existing data, and we're just focused on collecting that cognitive assessment and those behavioral observations. So this is going to be our framework that we're going to walk through today. So let's move into reviewing existing data. And we're going to hone in on generating an excellent referral question and how to do a comprehensive record review. So the information that we're looking for, this existing data, this is a list that Dr. Rich and I try to use in our clinical practice, but in our school-based practice, we were taught, essentially leave no stone unturned, right? But all of this information together gives you a really good picture of the child's performance over time, across settings, even across raters when you have, or instructors when you have multiple years of data, to give you that picture of, is this behavior, is this deficit consistent and matches with the disability. And so we've got different areas that we might pull documentation of, everything from classroom performance, attendance. I'll say that one again, attendance. If they're not there to learn, attendance, then they haven't had the opportunity to learn. Previous test performance and discipline records, school transfers, any information the parent provides. I have had parents be frustrated because they've given a copy of a report to the school and it sat in someone's filing cabinet for months and didn't, get integrated in. Any relevant health information. This is one that I see schools skip over a lot because they get really focused on, well, we're in the school, this isn't medical school, but collecting that current health information is important. And any previous psychological or psychoeducational evaluations. I will tell you, in my interviews with parents, and when I first make contact with them, that's the first question I ask before any, we talk about their referral concern. And then I say, has this child had any type of psychological testing or testing through the school? Because it really gives you that foundation for your questions and what other information you need to gather. So again, the conclusion of getting all of this information is generating that specific referral question, any noted concerns, and recommendation if we need to do further evaluation, because we may not need to. We may have all the information that we need when we've gathered it together. But if you do need to do further information, gather further data, this information is going to help direct that process. And it's also going to give you information about what the parent, what teacher, what others are really hoping to get out of the evaluation. It's not going in blind. Next. So you've got a nice little checklist. Who doesn't love a checklist, right? So guiding questions that you can use as you are going through this review of existing data. So, did we have the information on current presenting concerns? Health information, hearing and vision screening. I repeat that multiple times because I had a practicum student who had been in another site, and a child that they were evaluating for intellectual disability, they had been placed in the categorization of ID for years and had never had an updated vision screening. Turned out the child needed glasses, and it made a huge difference to their score. They did not qualify any longer once they were taking it with appropriate glasses. So primary home language documented, because that's going to guide the assessments that you use. Any home or background information that may affect performance, situation instability in the home, any kind of traumatic experiences the child may have been exposed to. And at the end, did you develop this conclusion and the need for further evaluation? So example, we've got our first grade student who is significantly behind in their academics. I'm going to do my comprehensive record review. So looking at their attendance, they've been to school 95% of the time, both kindergarten and first grade, and haven't had any discipline problems. But when we looked at their kindergarten readiness screening, they were significantly below across multiple developmental levels. So fine motor skills, language, cognitive abilities. When we looked at their academic records, they didn't pass either their kindergarten or first grade screening. And even though they've been receiving early literacy interventions, they haven't made much progress. That's why that progress monitoring data is so important. So when I get to this evaluation, so I can see it. They passed both their hearing and vision screening. And so when I went to do the interview with the mother and the teacher, the mother's reporting they had delays in language and motor skills, but no chronic health issues, anything concerning. The teacher is reporting that they're really struggling. They're struggling with completing assignments, following directions. They're lost. Oftentimes in school. So, we joke about being in la la land, off in the head in the clouds, but when they're interacting with their peers, they do really well. They enjoy talking to their friends, and they're not seeking out being alone and withdrawn. Very important to note, as a first grader, academically, she's not able to remember, or he is not able to remember letter names or numbers. So this is where we're going to start. We've done the record review and the interviews, and then Dr. Rich is going to start moving us into the process of collecting new data.
Yeah, thank you. So just going to point out, we're going to keep returning back to this example, but you can see, and this is often the way it works in schools, like the teacher comes and says, I'm concerned about this kid's academics. I'm concerned about their progress. But then as we start digging in, it's like, maybe there's a larger concern here than just academics. And so for this one, that conclusion was really, should we be looking at intellectual and adaptive functioning for this student as well? So that's sort of getting into that suspected piece there. So then the next step is collect data. We don't have enough yet to know what to do. And so we're going to collect comprehensive assessments utilizing a variety of assessment tools. So I like to throw this slide up here just for sort of some legal jargon, but I think it's really important because I don't know that a lot of us in special education realize that the federal IDEA law actually defines broadly, but it defines what type of evaluation we should be doing. And it says a full and individual initial evaluation. And then it defines what a full evaluation is, in that it uses a variety of assessment tools. You're not using just one single measure as the sole criterion for identifying a disability. So you have multiple assessments and multiple pieces of data, and you're making sure you use technically sound instruments. So these things are not just best practice, which hopefully we know they're best practice, but they're actually legal requirements as the standard of practice. And so I think that's really important. So we're going to talk a little bit more about what does it mean to be using multiple sources of data and technically sound assessments. So variety of assessment tools. So basically we're using multiple methods. So a lot of times when individuals hear the term, we did an evaluation or we did an assessment, they're thinking of more of those standardized individualized assessments, like an IQ test, an achievement test, or a rating form. But I encourage you, when you're thinking of a psychoeducational or a neuropsychological or psychological evaluation, that it should include something from all of these different broad categories. So we just talked about record reviews, incredibly important to know where you're starting at. Then there's the interviews, and interviews for children, we're talking about interviews with the relevant adults in their life, and then as well with the child. And even my 5-year-olds, my interview might be, what do you like to do for fun? What's your favorite toy? What TV shows? But just getting some interest in that child. For my older ones, that interview is going to dig more into their own understanding of their difficulties and their goals and what they're seeing as areas that they have areas for improvement. Observations are incredibly important. I will tell you, as Dr. Stein mentioned, we both have worked in school settings, and now we're working in more of a clinical private practice setting. The thing I absolutely miss about the school setting is getting to do those observations in the schools with the students. So my observations now are more clinical with the family in the testing setting, but it's really important to do those observations in the students' most what we call naturalistic setting. This can be a formal, like I'm marking down on task behavior every 10 seconds, or it can be a more general, like narrative observation. And there's benefits to both. It's really up to the person doing the evaluation, looking at the referral concerns to determine what's most appropriate for the situation. And then we get into those assessment tools that are a little more what we think of when we think of assessments or evaluations. So the rating forms, a lot of times things we're rating are behavior, emotions, social skills, and adaptive skills. And a lot of times sometimes it's self-rating forms, and sometimes it's ratings of the teachers or parents rating how the child feels. So a couple of things to know about this. One, we always like to have multiple informants. And so I like to have parents, both parents if possible, teachers, multiple teachers if that's applicable to the setting, and then also the self-rating forms if the child's old enough. Even with that, I'm looking for convergence of data, but it's important to note that rating forms are not a measure of behavior. They are a measure of perception. So thinking about that, this is how, when we say there's a question of, can't stay seated, and the parent rates almost always. That's the parent's perception that the child almost always can't stay seated. Now, if I did an observation and measure that, would that child really almost always be out of their seat? I don't know. That's why we like to have the observations and the rating forms. And so I think it's really important when we're looking at the data to understand that that's the perception of what's going on, and why sometimes we have teachers' ratings indicate not a lot of concerns and parents' ratings indicate a whole lot of concerns, because parents have different expectations for their behavior and different perceptions of the behavior than the teacher. And then the assessments are usually more direct measures, individualized, working with the student one-on-one. Sometimes these things are directly measuring skills, like an oral reading fluency assessment directly measures how fluent and accurately a student can read words. A measure of cognitive ability, let's say a working memory task, measures more of a theoretical perception of processing skills, and there's not a direct link, like if a child can do well on working memory, then they can do well on this academic task. So just knowing that, again, when you're looking through those evaluations, the more cognitive tests might not have a direct correlation to work in school. The academic tests are probably going to have a more direct correlation. And then we also do things like motor skills, where we're directly assessing motor skills, speech and language skills, excuse me, sometimes more specifically like articulation. And so you might, again, have a team process where multiple professionals are doing an evaluation of the student, measuring different areas that they are expertise in. When we're doing these measurements, especially those standardized measurements of the rating forms and the individually administered achievement, cognitive, language, motor assessments, we want to make sure they are what we call technically sound. And this gets into the weeds, kind of some nerdiness coming in. So if you're like me and you like data and you like research, you're hanging on. If not, hopefully I explain it in a way that provides like the basics of what you're looking for. So we're looking at reliability, validity, and usefulness of the assessment. So on reliability and validity, reliability means when I administer this assessment and measure this skill, I'm consistently and accurately measuring something. I don't know what that something is, but I'm consistently and accurately measuring something. So if you look on this little graphic over here, we can have high reliability, but not necessarily on target where we're measuring what we want to measure. So this kind of our target clusters over here, we're consistently measuring something, but we might not be measuring what we want to measure. Validity means you're consistently and accurately measuring what you want to measure. You have to have reliability to have validity. So this one is high validity and high reliability over here. When you have low reliability and low validity, it's just scattered all over the place and you're not consistently and accurately measuring anything. More practical example, something that we've all probably used this little tool recently with the cold and flu season and RSV and everything else going around, that digital thermometer. I expect my digital thermometer to be accurate, to be reliable and valid. It pretty much is. And if I take temperature readings within 10 minutes, 3 temperature readings, I get 98.3, 96, 105. That's not reliable. That tool is useless now to me. It doesn't mean anything. Like, do I have a temperature or do I not? I don't know. That's not a valid or reliable assessment. But if I get 98.4, 98.2, 98.3, well, now we're kind of hitting at the same area. Like, yes, this is reliable. I can confidently say my temperature, according to this, is somewhere around 98.3. But what if I get all of those readings, but when you touch my head, it's burning up and I'm sweating and I have chills and I feel feverish? Well, now I might be getting a reliable reading from this, but not a valid assessment of this. So this is something we have to consider. Again, we're pretty used to, we just accept a lot of the tools we use have reliability and validity. Sometimes we need to take a step back though, when the assessment doesn't quite make sense, and we need to look into that a little bit more. For an academic example here, if you had a teacher gave 2 tests with the same math problem set, so like drew from the same set of problems, they're just all mixed up, and one day that student scores 80% and the next day they score 25%, well, something's affecting the reliability there. It might be something about the actual test, or it might be a difference in the test environment. Like one day there was a lot of distractions and the other day there wasn't. One day they took it by themselves, the other day they took it in the middle of the class. So there's something affecting the reliability of those results. It might, but if you had 80 on one day, 83% on the next day, okay, we're more reliable. Like we can reliably say we're starting to measure this child's ability to complete this set of math problems. But then, like our thermometer example, if we go back and so they're doing fine on that test, but then when I give them a worksheet or like a homework assignment that has very similar problems and they can't do it, something's missing from the validity of that assessment. I think I'm measuring their actual skills and they might have those skills, but something else is affecting the validity of predictive validity of those skills, and that score telling me how they're going to do on their math worksheet or on their homework. And this is where I see a lot of the tests that we give in psychoeducational evaluations. They're pretty good reliability. They have pretty good validity of like general validity, like this has been shown in research to show this matches with this skill, but the individual validity of like how predictive this is going to be for this individual student's performance, that's where it can be questionable. And that's why we recommend, the law says that we have to have multiple pieces of data and we can't just make a determination based on one sole criterion. And so I think that's really important to consider the full context. A situation where I see this happen a lot in outside evaluations that I get that have been done by other practitioners is they will give like the ADOS assessment. The ADOS has been shown to have, it's kind of considered your gold standard for autism assessment, but it's very clear when you read the manual that it should not be used alone, and it should not be used as the only indicator as autism. And I have seen multiple times that I get a report where the person has done the ADOS, they met the criteria for autism on the ADOS, and then a diagnosis of autism has been given. And there was no consideration of the child's practical skills within their natural setting. There was no consideration of parent perspective or early development or these other things that might be contributing to that. So that's why it's really important to have those multiple sources of data when you're making any kind of classification or diagnosis in that evaluation. So if you're like, stop talking about reliability and validity, this is boring. I just will give you this little resource to look into. So if you need to know what the reliability and validity of an assessment is, the technical manual. So if you have an actual copy of the assessment, that will give it to you. And there is this nice little handbook that is produced every year called the Mental Measurements Yearbook, and they will publish just a short little paragraph on different assessments and what the reliability and validity standards are for that. You can also look peer-reviewed research articles, or ask your friendly neighborhood school psychologist or psychologist. And we're usually pretty nerdy about this stuff, and we're happy to find it out. If you do start looking into this on your own, just know that numbers closer to 0 indicate less reliability and less validity. Numbers closer to 1 indicate more reliability or more validity is the way to read those. So your numbers are going to be between 0 and 1. 1 is better, 0 is worse. Anything 8 or above is usually considered pretty good. Some like IQ testings, we're really looking for 0.9 or 0.95 and above as being acceptable reliability. Now, this is another piece. Is some people consider this part of validity, but I think it needs to be pulled out as a separate topic to really think about is what's the usefulness of the data. As Dr. Stein was talking about the DSM, that a lot of times the usefulness of the assessments that we're doing related to DSM-5 criteria in a medical setting, the usefulness is just to draw attention. We're just saying there's a problem, this is your alert sign. But in our schools, it's really important that the data we're collecting is actually tied to something that can be used for decision making, that it can be used to identify, is there a problem, but also how do we target that problem and what do we need to use to address the problem. So when I'm reviewing evaluations that have been conducted by the schools, I'm looking for a match of, there was this initial review of existing data that said, this is the problem. There were assessments that addressed that problem and evaluated it more consistently. And in that assessment, it's tied to some sort of goals or outcomes or other assessments that were done to follow up. And so we can identify our goals and what we want for our children, whether or not they're receiving special education services or not. And I think that's the other important thing, that a lot of times kids don't end up with diagnoses, or they don't end up with a classification. They may not qualify for special education services, but hopefully that data is going to tell us something about the initial area of concern and what we can do about it. So not specific to special education evaluations, but just thinking in general, all the kind of data we collect in our schools. If you have a reading benchmark that identifies not only which students are below level, but also include a summary to identify which targets for interventions, or you have a reading screening, then you follow up with a diagnostic assessment of, hey, the student needs to work on letter sounds, then that's going to give you some information about what interventions, what services that student should receive. Whereas if you just have one that says, yep, they have low early literacy skills, and it doesn't really tell you what early literacy skills they're low in, that's not going to be that helpful, and that's not that useful. Or thinking about office referral data or behavior discipline data. If it helps you identify when the behaviors are occurring, why they may be occurring, who is it happening, what behaviors are occurring, that's going to be a whole lot more helpful than just a summary of we've had a lot of problems. There's a lot going on. And so we want to think about the usefulness of the data that we're collecting. So I have this on here, the next few slides really is just resources for you. This is Rob put the link to the handouts in here or to the slide presentations, and it will be posted with the recording because there are tons of standardized assessments out there that assess a lot of different things. It is a huge money-making business for test publishing companies. This list is not comprehensive by any means, but it is some of the most common ones that I see in our practice, especially in Oklahoma. These are sort of the common assessments that I see in these different areas. And I put this up here as a resource for you. So if you comes through and someone gives you the acronym of, we did the BBCS, and you're like, I don't know what that is, you can look over here and say, oh, that's a developmental assessment. Or if they did the C-TONY, that's a nonverbal cognitive assessment. So just to give you guys this as a resource guide. The other thing to pay attention to this is next to each of the acronyms, I have put the publication, the most recent publication date. And that's really important to note because sometimes assessments take a long time to update and re-norm, and it's really not best practice to use out-of-date assessments. So if someone, for example, just this year did the WJ3 cognitive assessment, well, I'm not going to trust that data because the WJ was updated to the WJ4 in 2014. So they're 9 years out of date. So we need to be using updated assessments. This is one of the many reasons why we need to be using updated assessments. So there's this theory that has been verified several times in research. There's some question of exactly how much of an effect it has, but research has very consistently shown that the IQ of our general population is increasing over time. So the test that we would have given, like on the original WIS score, that score is increasing over time. And so we have to update the norm group that we're using to compare each other to. And I'm going to get into normative evaluations and assessments here in a second, so this might make more sense after that, but just wanted to put on there that there's this idea called the Flynn effect. As a general population, our scores are increasing over time. So if we're comparing someone over here in 2023 to a norm group in 2013, there's going to be a difference there. And the general theory is that it's about 3 points every 10 years that we're increasing over time. And we also see similar things to academics. And you also think about the difference in curriculum expectations from now to what they were 15 years ago, 20 years ago. We have to keep those assessments updated. So it's not just a money-making business for the publishing companies, but it also has some purpose in making sure that, again, our data is accurate and reliable and valid. Same thing with the with the assessments, like the standardized assessments. I wanted to list out the common rating form assessments as well here. And with that, again, it's not comprehensive, but these are the common ones that we see used in schools for your reference there. So just to kind of revisit that idea of the DSM assessments versus the IDA assessments, because like Dr. Stein said, this is where a lot of the misunderstandings and miscommunications come within the school systems when parents either have had an evaluation done or they feel like the school's telling them to go get an evaluation from a special or from a private practice. Just knowing that when schools get those private practice evaluations, the focus is most likely to be on very standardized assessments and rating forms. Whereas the academic IDEA assessments or the educational assessments, they're going to focus more on academic, educational needs, and they're going to have access to a wider variety of sources of data because they have observations, they can collect data in the classroom, they can do a better sort of naturalistic evaluation. Those more medically focused assessments might have more what we call neuropsych testing, where they might be assessing like attention skills or visual motor skills. A lot of times it does not include academic testing. If it does, it's usually pretty brief, and it's more about kind of evaluating the overall concept of this disability, not specific components to evaluate. Whereas in the education setting, it's cognitive assessments, and those things might be just brief and to rule out different disabilities. And they're going to be focused more on the components that are outlined within whatever state's policies and procedures. So in Oklahoma, we actually just updated our policies and procedures, and there's very specific components, not individual tests, but components that need to be evaluated for the different categories. All right, so back to our checklist. This is on that handout. If you have an evaluation you're reviewing, or if you're like, did I do everything that I needed to do? Did I consider everything? These are some things to look at. So first of all, did the person do the evaluation tell you what all they did? And did they use commonly used or up-to-date assessments? If an uncommon assessment was administered, is there evidence of reliability and validity of the assessment? So I'll give you guys my most recent example of this is that I had a child in my office who I actually ended up diagnosing with selective mutism. So meaning that he could speak, but due to anxiety and trauma factors in his life, he did not feel comfortable speaking with people outside his family. And so I got him to say maybe 1 or 2 words, but very few words. He mostly communicated with pointing, gesturing, or would look to his father to help communicate for him. But they brought in, and the parents were concerned because he had an evaluation that said he had an intellectual disability. And they brought me the report of it. And the person that had done this assessment used an assessment that I had never heard of. So it wasn't one of my common assessments. And so I started to look into it, and they had actually done a virtual assessment using a test that is primarily designed to use for individuals who are visually impaired. And so it's a very verbally based assessment. So think about this. We're evaluating a child who has selective mutism, barely speaking, and we're using a verbally based assessment. There's a mismatch there. It might be a reliable test for individuals with visual impairment, but it's not a reliable test or a valid test for individuals who have verbal deficits. And so I was able to do a different assessment, a nonverbal one, and demonstrate that, yes, in fact, this child does not have an intellectual disability. So thinking about that, when you see those uncommon assessments, really dig into why was this done? What was the purpose of it? Again, ask a psychologist to help look into that for you if you need assistance with that. Thinking about the cultural and linguistic factors, same thing with that I just talked about, but is English even the primary language? Were there any adjustments? Has this test been normed on individuals who come from that background? Was more than one method used in an appropriate time frame? And then, did the assessments relate to the referral concern? Was there a match? Did it make logical sense? And I will tell you, even if you're not a psychologist, you're not a psychometrist, you're not trained with this, but if you're reading a report and it doesn't make logical sense, go back and ask the person that did the evaluation, because it should make logical sense to you of what was done. So thinking back to our little first grade student that we're concerned about here, significantly behind in academics, we're thinking maybe this is an intellectual disability. So this might be an assessment plan for her. We might do some more developmental history. Mom said she was delayed, but dig into that a little bit more. Observe her with interval recording in the academic setting, as well as with social, and doing some just kind of informal observations in the social setting. Getting rating forms on those adaptive skills, but also on behavior and social emotional things, and seeing how she's doing with that compared to where we expect her to be with her peers. And then doing some individualized assessment of the WIS, the WIAD, Ames Web, and potentially a language assessment like the CASEL. So we've reviewed the data, we've made an assessment plan, we're collected the data with that assessment plan using reliable and valid assessments that hopefully provide useful data. Now we have to synthesize it. And this is really where the work comes into place of this, what we call kind of cognitive work of synthesizing all of this together into a cohesive manner. And a lot of times it doesn't just lay out cohesively. A lot of times we have some data over here indicating this, some data over here indicating this. And so the work of a psychologist, a psychometrist, a speech language therapist, occupational therapist, to take all that data and kind of put it into the bucket and see, on this bucket, where is the concerns really falling? What is this picture really turning into and looking like for this individual? So one of the ways we do that is interpretation with standardized test scores. Standardized test scores can be really helpful if you understand them. They can also be really helpful to make a case that's not there if people are trying to use them in inappropriate ways. And so again, this gets into sort of the nerdiness, but I think it's really important for consumers who are reading evaluation reports to understand the differences so they understand really what's being said in these assessment reports. So first, let's back up and look at, there's criterion referenced assessments and there's norm referenced assessments. Criterion referenced assessments are going to be tests that compare a student's knowledge and skills against some sort of predetermined cut score or criterion. So if you think of like like measuring height, we're measuring that against a yardstick. We have some sort of yardstick that we're measuring that against. Whereas a norm reference is going to compare that person to a group of individuals, and you're going to fall into like a percentile. So again, thinking of height, your child may be, 3 feet high, and that might be at the 50th percentile compared to other children their age. And so we're comparing them to that group, and it depends on what that group looks like will change what the individual looks like. So when I talked about that Flynn effect, that group of individuals, if we're comparing that group to a group of individuals from 20 years ago, that's going to change how that individual looks like compared to that group who may be, or compared to a group who is present day. Then we also have differences in where we get those norms and criteria. A lot of the assessments that we're doing for psychoeducational evaluations, we're doing them based on national norms. So they're trying to collect a pretty good sampling of individuals from across the nation that represent lots of different ethnic and socioeconomic groups and disability groups. Sometimes we also have criteria. So for like our reading sufficiency screeners in Oklahoma, most of those use some sort of criteria that was set, like you have to score this on Ames Web to meet the set criteria, and that's based on a nationally set criteria. Sometimes they use a combination of criteria and norms, like percentile is based on the norms, criteria set with the individual score. Other times we might be using local. So we might have local norms that are to Oklahoma, or we might have local norms that are to your district. This is less commonly used for evaluation and diagnosis, and more commonly used when we're measuring like response to intervention and progress monitoring. All right, so these are the different types of scores. Again, this is for your reference, but I want to point out a few of these that are often used and ones that are often used inappropriately. So raw scores. Raw scores, like I had a test with 20 questions and I got 10 of them right. They are not helpful for interpretation, especially when talking about standardized assessment. So if you're reading a report and someone has just given you the raw scores and no interpretation of what that means, that's not helpful. And that really, we hardly ever report raw scores. Standardized scores, this is what's helpful. My next slide is going to show you different versions of standardized scores, but these give you that relative performance to the mean or relative performance to the criterion. Percentile ranks are also really helpful because they're pretty easy for parents to understand. Because again, like we use percentile when we're talking about weight and height, that all those well child checks. So we can say, a percentile rank of 50 indicates that they scored at or better than 50% of other kids their same age. Sometimes we say their same grade because we're comparing to the same grade group. Comparing to the same grade group and age group is not the same as an age equivalent and a grade equivalent score. So let me say this another way. A grade equivalent or an age equivalent, which you'll also often see as abbreviated AE or GE, they indicate that that student had the same raw score, not the same skill level, but the same raw score as an average student at that same grade or age. So this student scored the same number of problems correct as the average third grade student, but they may have been given first grade level skills. So on first grade level skills, they got a raw score of 10, and your average third grade student on third grade level skills gets an average score of 10, but they may or may not have had overlapping questions. And so it's really, grade equivalents and age equivalents are often misleading. They're used because people think they're easy for parents to understand, but when you really dig into what they mean, they don't quite mean what they sound like they mean. So when I say a person has an age equivalent score of a 10-year-old, that doesn't mean they can do all the skills of a 10-year-old. That just means their raw score equaled the same thing. So I just want to put out kind of that warning, flash, caution that when you see age equivalents and grade equivalents, they can often be misleading. The one area that I think they are more useful is when we're talking about adaptive skills. And adaptive skills can again give you an estimate of their age equivalent on those adaptive skills, but should not be used in isolation. And we should never report only grade and age equivalent scores. For those standardized scores that I talked about, these are different standard scores that you may see in a report. Most IQ and achievement testing and language assessments will use what we call a standard score, which is abbreviated SS, and that has what we call a mean or an average of 100 in sort of a range of average from 85 to 115. So usually IQ scores are indicated to be in this, like overall achievement scores, big, broad scores that measure a lot of different things will combine into a standard score. Some tests will then give you what we call a scaled score, or S, which is an average of 10 and sort of a range of average from 7 to 13. And those are usually like the individual subtests. T-scores is a common one that we use in rating scales, and T-scores might have a mean or an average of 50 and a range of average from 40 to 60. I will put a little caution on here that sometimes T-scores, like higher T-scores, indicate more adaptive or more appropriate functioning compared to their peers. But for a lot of our rating forms, like the BASC or the Brief or the Connors, higher T-scores indicate more concerns and more inappropriate behaviors or maladaptive behaviors. So high T-scores are not always a good thing compared to the norm group. And then stay-nines, we hardly ever use them, but they're on here and you can see their range there. This is just, again, for your reference, you can Google normal curve. I think this actually comes out of a speech and language literature, but I just like it kind of to use to explain to parents of like, what does this mean when we're talking about that normal curve and a child has a score of 100, it's in the average range compared to others in that percentile rank. This is another, so there's some different language that different evaluators will use to qualitatively describe their scores. And so this just gives some different language that might be used within those scores, again, as a reference for you. So I want to talk just a minute about, I've talked about a lot of different types of scores, type of assessments, and there's different uses for different types of scores. So when we're talking about a disability identification, we're usually going to use that norm reference, and usually nationally norm reference. So we're usually using like a standard score, an IQ score of this indicates they're at this percentile rank compared to their other peers their age. We might include some criterion reference, but that's not going to be as much. And we may include some intervention progress monitoring data, especially if we're looking at specific learning disability, dyslexia, considerations of learning progress. When we're identifying needs, so that more useful data, that's going to come more from the criterion based and those absolute levels of performance. So scoring reading 125 words correct per minute on a reading fluency is a lot more useful information for determining if a child, what type of intervention they need, than telling me they had a standard score of 85 on a reading fluency achievement test. I don't know what that score of 85 means. I know that a reading fluency score of 125 means they could accurately employ and read 125 words per minute, and that's more useful. And we might be using some like those dyslexia screenings or other skill specific assessments. Progress monitoring. This is a tricky one and another mistake that sometimes I see, and I'm going to show you a couple of slides like why it's a mistake, is that we need to be using actual either raw scores or criterion scores to measure that progress over time. You cannot use normative scores. You cannot use standard scores to measure progress over time. And the reason for that is, remember that normative assessment is just telling us where they are relative to their peers. Well, their peers also grow over time. And so even though the child may know more information each time we're evaluating them, their peers also know more information. And so that's why they might stay in that 30th percentile every single time, because their peers are also growing with them. So that's not a good measure of progress. This is why we say IQ is relatively stable over time. It's not because IQ actually stays the exact same over time and we only know so much. It's because everyone else is growing with us. So when we're assessing growth, it's better to have a criterion, like we want them to be at this level, and how do they compare to that level over time? Or just individually growth, like where were they last time to this time to that time, and it's called ipsative assessment growth at that time. So, and I see Charmin, one of my friends out there in the school psychology round, put on there, where would the rate of progress improvement scores or RPIs fall on this chart or on the chart related to those standard scores? That's another measurement that's a little bit complicated, and research indicates it's not always the best measurement for actual skills and measuring those assessments. And so I don't have it on here, but I'd be happy to talk with you more, Charmin, about that and how that all puts into there. But I would say that RPI, kind of like grade equivalents and age equivalents, they should not be reported alone. So they can be reported, but they should not be reported alone, and it should be considered with the standardized scores. So again, back to our checklist of looking at that data synthesis and putting all the information together. Thinking about, first of all, does the evaluation report tell me were norms, were criteria used, were normative data? Did those norms match? Like my kid, that, hey, we're using visually impaired kids over here, and my kid doesn't have a visual impairment. Oh, sorry, I was thinking rate of improvement. You were relative proficiency index, Charmin. I see that. I think Brittany is working on an answer for you there. So thinking about the appropriate of the student demographics. So for example, if you look at children who have English as a second language, and thinking about that piece of it, that a lot of assessments will include children who might have English as a second language, but what was their cultural influence? Did they grow up in the United States? Did they immigrate? How long have they been exposed to English? Like all of that stuff, it should be considered as well. It's not just a matter of, okay, this child speaks English in this normative, or this child speaks Spanish and this normative assessment speaks Spanish, because those can be very different things. And does the data converge across multiple settings? So going back to our example here, our first grade student, lots of information or behind in academics. So we do that developmental, and yeah, it's looking like, you know, she was delayed in crawling and walking, using speech, even like using utensils, and has been receiving private practice therapy since she was 3. So there's a history there of delays across multiple domains. When we did observations, you know, she was on task 60% of the time. Her peers were on task maybe 80% of the time. During lunch and recess, she interacted with peers, so we're not concerned about the social pieces of it. Rating forms indicate teachers' perception is pretty low, like a 65, and 70s are cut off for being very low. 65 is very low, and 75, parents' perception's a little bit higher, but still pretty low overall. No concerns were presented on the BASC for other things like social, emotional, behavioral things. And then we look at that WISC, and yeah, like it's looking like we've got a child who's got some intellectual deficits here. Across with verbal, and when we take out the verbal and the WISC, Wyatt scores were pretty low. Ames Web, low on academic assessments. Language is pretty low. So this is a student that we're looking at. We're like, yeah, it looks like everything is pretty consistent with intellectual deficits here. I will say this is a made up case. They're not always this clean, but I'm kind of going into that and just seeing how all the data may converge or what it may look like there. And I'm going to hand it over to Brittany to wrap us up and talk about how do we report this data and what does it mean? And I will also keep my eye on the chat for you, Brittany.
Yes, and well, I wanted to answer Joanne's question that you all may not be able to see it, but she put in here recently. She said recently I've been asked by a parent about their child's broad cognitive. They mentioned that the subscores had pretty large range of scatter. What did those scatter scores tell the parent about their child's intelligence? That's a great question, especially because the answer to that has actually changed during the time that Dr. Rich and I have been trained and then been in practice. And the latest research and the consensus in the field is a saying, scatter doesn't matter, and that we should only be interpreting that broad IQ score. So, you know, especially when we're looking at intellectual disability, things like that, you're going to have splinter areas that are going to be higher, lower, but when they run, you know, the statistics and analysis on it, like what is actually accounting for that, like we shouldn't be interpreting those. Now, I will say, one time I do look at those subtests, and rather more the composites, is when I have a child that I really question their verbal skills, language proficiency. Well, I will look at the subtests that are more verbally loaded, so require a higher level of verbal skills, or the ones that are nonverbal, to see how they performed on those. You know, sometimes I will look, and like I had a child 2 weeks ago come in, and I did the feedback, and everything was in the average range they did really well on, except processing speed. Everything was incredibly low, and we were talking about the impact, but when they did the academic achievement testing with me, they were also in the average range, but they're really struggling in school. And we talked about how that lower processing speed, you know, what the different factors may be incorporating that, you know, but that it also may be impacting, you know, their ability to build fluency on things. Like they may be very accurate, but can't do things fluently. So that would be my answer to that, but always hold true to the scatter don't matter. So, so as we're walking through the end of this, we're going to look at the components of a comprehensive report. And this is contentious, Sarah, you can skip to the next slide. I guess I shouldn't say contentious, but now you're seeing a lot of psychologists, qualified examiners, school psychologists, qualified examiners, speech pathologists, only put the results of their testing straight into EdPlan. And they just stick in the scores, they might do a little write-up, and I don't know, I might be old-fashioned, but I prefer a report because of the way it lays out neatly for the parents, that referral question, and all these different parts on the checklist that we talked about. And it is an extra step, admittedly, when, there isn't a lot of time, but, all qualified professionals should contribute to the narrative, and we need to have a list of everything that was administered. This is key because when I make an assessment plan, a test plan, there are often assessments that I don't get to, that maybe I couldn't score because we weren't able to do standardization correctly. Other concerns or issues, but it shows what was planned. I'll tell you, this happens quite frequently when I do assessments with kiddos with low incidence disabilities. So they have behavioral challenges, and then I have insurance companies or schools come back and say, well, how can you prove that they have autism? Well, I can show them this is what I planned. Here are the behavioral observations. Here's why I wasn't able to report a score. So always put in all of those things and then what could be causing it to be invalid. Part of the narrative should have their performance as it relates to disability criteria and how it's used to do services. So that summary piece is really key, and actually linking it to the categorization, not just showing the results and then we sit in the meeting and determine they're here. It's really important to link, and I am also a fan of showing why they don't qualify for certain areas. If we were considering multiple categories, like why didn't they qualify for autism, but I chose ED instead, or recommending ED. So next slide.
I will say, as we're going to the next slide, because I completely understand the time crunch and commitments for our school psychologists and speech paths and OTs who are overworked out there. As I'm reviewing MEGs as an outside professional, even if they didn't write a report, I am looking, did they include this information in the ed plan and the MEG? So like Dr. Stein was saying, it's nice when we have a report, but if there's not a report, was that narrative space used for all of these things that we're talking about? So the same checklist applies no matter what format you use.
And so here's what needs to be included in that result. So we love our tables, our checklists, so you can go straight through, but essential, you should have each assessment and a description of that assessment, the standard scores and what those are. It's ideal to include the confidence interval, but also include somewhere in the report what a confidence interval means. The percentile ranks. I find this is one of the easiest thing for parents to understand. So including the percentile ranks and an interpretation of the score. So that again is part of the narrative, not just reporting the numbers, but what those descriptors mean. Composite scores, often, like we talked about, we mentioned scatter doesn't matter when it's talking about the broader IQ score, the full scale IQ score, but composite scores are going to be more reliable. So in my assessments and reporting, and I know Dr. Rich does the same, I report full scale, composite scores, and all the subtest scores. That's also going to be beneficial to clinicians doing school-based professionals doing future evaluations. If I see that 3 years ago someone else gave a WISC and I just gave one, I'm going to look and compare how they did on the different subtests, how they did all of the composites. So it's useful information. And any modifications that were made to standardization. So, what their attitude, if they seemed like they were giving up, and you have kiddos that don't do as well on their testing because they're really just giving like their first answer. And then you may prompt in the standardization, it asks you to prompt, but they say, don't know, I don't know, that's it. That's a very different responding than a child who is continuously trying and not getting frustrated easily. Or if you have to end a subtest early. So next. It could be useful to report what the raw scores are, what their age and grade equivalents are. Again, Sarah talked about that earlier, what the caution is with those. You really have to weigh out not just how you use a score or how you may be explaining it in the context of the meeting, but also what that data does going forward. Because just because I write a psychological report, it is a stamp in time and those words are on there, but I can't control once it goes out of my office who has it, who's interpreting, how they're using it. And so if you are going to use those, including like how that information should be used, how it should be interpreted, because if I sent you with just a score printout of WJ scores or then, without any interpretation, someone could get a hold of that and say, oh, see, their grade equivalent is this, and this says on here, so this means X, Y, and Z. So it's really important to have that narrative and explanation. And then other types of scores may be included as needed. Next. So we want our statement on what the primary purpose of the assessment was, all of our relevant background, all the procedures and assessments we've used, statement noting the limitations. This is really critical. Most psychologists, school psychologists I know have included statements of limitations about COVID and what's that has done in terms of interpreting norms on student academic achievement, even cognitive achievement. So a lot of our cognitive assessments, for the most part, I heard this last week as well, talking about they measure what a child knows as well as what they think. And that knowing piece is a lot of knowledge and achievement based. And so, the impact of COVID on that could change up their cognitive scores as well. So, summary of the results as they relate to the referral question and those answers to the referral questions. So don't just leave them hanging with just the questions and no answer. But we answer the question and then we say, what next? And make recommendations of what to do. So questions that we might ask, was the data collected to rule in and rule out? Does it converge across multiple methods and sources? So, someone else may have given all of the assessments, but are they paying attention to the fact that, teacher is saying that they're bouncing off the walls, can't sit in their seat, calling out all the time, but mom says that's not a concern. Is that indicative of a disability or is that something situationally specific, right? Did we measure the relevant skills related to the disability that we're considering? Were they interpreted with the context of the student's environment, background, school history, observations? And were all the components present? So really critical things to consider. So our example, we've got our relevant background. They were delayed in development, receiving OT and speech since 3, the medical issues, birth issues. We said hearing and vision intact, has a history of academic difficulties. We did observations, rating forms, IQ test, academic test, language assessment, and the presented scores, we think they're valid of their current abilities. So weren't having extensive behavioral issues in testing, not paying attention. Observations, slightly off task in class, had difficulties with lunch routine, but was acting with peers well. No concern about her attention or focus during the eval, but sometimes she needed test items repeated. So next. So then we developed our summary. This indicates she has significant delays across cognitive academic area or adaptive areas, overall low IQ for her full scale IQ, as well as nonverbal reasoning, difficulty with independent functioning based on our adaptive rating forms. So for the referral question and answer, she meets the IDEA criteria for the category of ID. Her scores are well below the expected level for her age, and we're seeing the significant deficits in academic performance, which require specialized instruction. So we've determined the category, that she has a need, and that the need requires special education programming. See, it was that easy, Just took about an hour and a half. So then we provide the recommendations, right? And this is going to guide with helping create that IEP. So specialized instruction with areas identified on her aims of assessment, providing visual prompts for completion of everyday routines, access to peers in Gen Ed for social skill development, and we're going to reevaluate prior to turning 10. Okay. So I know that Joanne messaged that she's got a question for us, and if anybody else has questions, we are more than happy to answer them.
Okay, are you ready for my question?
Oh, we're so ready.
Okay, so in our center in CERC, people call us when they have problems with their child or don't understand what's going on in school. And I find that pretty consistently, parents really don't understand anything about the evaluation.
Yeah.
They really struggle with that. And, it is under the law required that somebody be present to explain the results. And I would like to say, I think that narrative of some kind is so important, because parents report to us, they're in that meeting and they hear all these scores and they're telling them things, but they leave the meeting and they were like, what was that? So they need something to look back on, because scores alone is not going to help them understand. And I think school people, meaning well as they do, forget what it's like for somebody to be in that meeting as a parent and not really understand what's happening. They often don't understand what decisions were made in the IEP. And I think it's important for schools to know to kind of slow that down a little bit. And I'm wondering if you have any suggestions on what might help the parent understand. Like, I was wondering if that bell curve sheet could be used for some scores to say, here's where your child would score. Do you know what I'm saying?
Oh yeah. So it's interesting. I will tell you, in our, we have the psychological internship consortium here in Oklahoma, and we had another psychologist come and present, and her daughter has an intellectual disability, some medical disabilities, and she told us that she couldn't stand when professionals used the bell curve because of the way it had been used, and felt like it was insulting at times, showing like, oh, they're so far behind. But, I think it can be a really useful tool in terms of showing where the child falls on specific skills. What I think is helpful, and what we use in our clinic, is we have a color-coded table that kind of plots out a scatter plot of all the scores, and it's like color-coded and has the descriptors, so they can see with each subtest like where the child falls. And I find that parents find that really easy to understand, so they can see like, here are all the scores that fall in the average range, here are all the ones that fall in low, average, or extremely low. But exactly what you said, our feedback sessions in the clinic range anywhere from 30 minutes to an hour. And I often start to see that glazed over look. And so I think always including the graphs, the pictures of the graph where you can, like the BASC results, parents have an easier time looking at that graph instead of just the scores. So including the graphs, and, we walk through the picture representations. So first, and then, have the descriptors and things. And I always tell parents, I'm more than happy to read it to you here. But what they usually feel comfortable is we walk through the pictures, and then I tell them, like, go home, take time to read over it. And then if you have questions, we can set up another appointment or another time to walk through it. And I think they also sometimes feel more comfortable, like you give them an initial, but that step to go back and process it on their own and read through it and not feel like, you know, the room full of educational professionals are just watching them while they look at it, if that makes sense. Does that
Right.
help?
No, that does help. And any kind of visual, I think, is helpful for the parent to give them some idea, you know, what that means. What is my child like compared to other people? Because I think the scores kind of go over their heads. Okay. Are there any other questions? Oh, there are.
Yeah, there are. So I was starting to type, but I think I can probably answer these a little bit better just vocally here. So one, I'll say to your question, Joanne, that's a huge area of research and development in the field of school psychology. And for any school psychology friends, NASP has a lot of resources on effective report writing. So I encourage you to look at that. So Renee asked about kind of thinking about adaptive scores and how that plays into looking at category placement for ID. So just to confirm here, so ID is the base level is that they have to have low IQ scores, not necessarily achievement scores, but IQ scores and low adaptive scores. And when we say low, we're talking kind of standard scores 70 and below. And so we can, and I was talking to my intern about this today, that sometimes you have a student who has low IQ scores, but because they've been receiving training on adaptive scores and people have purposely tried to teach them adaptive scores, they're a little bit higher. And so that's again why we want to have multiple sources of data looking at different aspects of adaptive when we look at that. And I will also encourage anyone that wants to join the State Department of Education, and Nancy Busen next Friday will be doing a session on the evaluation components, and we'll for all of the 13 categories, and ID will be included in that. So she'll go into a little bit more detail, but you do by letter of law have to show deficits in adaptive and deficits in IQ to meet the categorization of ID or intellectual disability. And then Charmin, yeah, I think you're right that we struggle over the terminology, right? Like we're saying average can be really confusing to a parent. And what does that mean to say average? And thinking about, normal versus typical, atypical, and then we're talking about like neurodiverse and neurotypical kind of plays into it. And like Dr. Stein was saying, we have to be really empathetic in the way that we present this to parents, and we're talking about their child here. And the thing that I always like to note to parents is I'm going to be giving you a lot of scores, you're going to be getting a lot of information, but no matter what I say today, your child's still your child, and they're still their unique person with their unique personality, and we're just trying to help them the best that we can. And this really is to identify needs. But I do see this as an area that as a whole, as educators, as evaluators, we can drastically improve, because I'm with you, Joanne, like all the time I get parents where I ask, does your kid receive special education services? And they say no. And then they'll go on to explain to me how they have an IEP for a speech, or they have this, and they don't understand, like they don't equate IEP with special education, or they don't know what a 504 is. And we don't always do a great job explaining that in those meetings. Any other questions or thoughts?
Well, I'm not seeing any. And I do want to thank you ladies so much for giving us this information. Want to tell everyone that our next Wisdom Wednesday will not be in March because of spring break, but we will do one on April 19th, where Rob Kiter is going to be talking about the IEP relationship reset. And that is a webinar about when there has been a strain between a parent and a school district, how they could work towards resetting that relationship. So Rob will be sending out more information. So thank you, ladies, so much. And I hope everyone has a wonderful day.
Thank you. Always a pleasure. Bye.